Thank you very much for that kind introduction. Good afternoon, everybody. I think Turkey is a little bit like Sri Lanka because by this time in the evening, everybody says, okay, enough, I have to go and eat or drink or rest. So you are the guys who have decided to stay. Thank you very much for that. I have a story to tell you, which I think is an interesting one. It's not particularly science, but it's a story. And the story is about this, the IHPBA, International Hepato-Pankreato-Biliary Association, and the concept of a global guideline. Disclosure slide. So the IHPBA, it vigorously promotes the biennial World Congress. I think by some distance, the IHPBA is the largest global meeting for HPB on the planet. Over 3,000 people come to that. There isn't anything else quite like it. It goes from ERCP, liver, pancreas, biliary, transplant, everything is there in one meeting. So it's a very big meeting. But after the meeting, and it's promoted very vigorously, everything stops. So in 2022, during the IHPBA Congress in New York, during the time that I was president of EAHPBA, we had a meeting with IHPBA and said, is there anything that we can do to try and fill this void after the meeting? And the IHPBA decided to form a legacy committee, which is still active now, to look at the Congress legacy. It's a little bit like the Olympic legacy committee to see what can you do after the Olympics. The 2012 London Olympics, they had a legacy committee in London and they used a lot of the resources locally. So the Legacy Committee has a clinical, financial, and an advocacy arm. The advocacy arm is political. I'm just going to focus on the clinical arm, which was this business, which was to consider producing a relevant clinical practice guideline, which is applicable to the entire IHPBA membership. The model that they chose to use, not me, was this, and this is something we did during my term of office. What we did was we reached out to all of these other societies, European Society of Surgical Oncology, coloproctology, gastrointestinal radiology, and cardiovascular interventional radiology Society of Europe. And we said to these people, if you would like to give some members to work together to produce a guideline, it's not an EAHPBA guideline, it's a joint multi-societal guideline. And it was to update Renee Adams' document on the definition of patients with colorectal cancer and synchronous liver metastases. So this was quite a success. It was jointly published in BJS and HPB, and we thought, let's use this model. If you look at guidelines, for HCC, I think the best guidelines are these, the EASL guidelines. There's a new version from 2024. But the issue with EASL, and I have worked quite closely with EASL, and they have supported this process, is that they say users of the EASL guidelines should be aware that the recommendations are intended to guide clinical practice in circumstances where all possible resources and therapies are available, which is not the case for most of the world. So this is the BCLC algorithm. It may not project, but you'll all be familiar with this from very early, intermediate, late. You'll be familiar with that and all of the treatment options that are available in that. I had some practical insight, and I said, because this is a late evening talk, I'm going to tell you a little story about this. I'm ethnically Sri Lankan. We can make it a little more complex. I'm Sri Lankan Sinhalese, because we managed a genocidal civil war over this issue. I go to Sri Lanka to teach, and two of my former registrars are now professors of surgery there. So Arinda Dharmapala, who is a professor of surgery in Kandy, said, can you come and do some surgery with me? So I said, okay, maybe. So I went to the Sri Lankan Surgical Congress in 2024, and afterwards he said, can you stay for a week? I have collected some cases. He did GI surgery in the way that many people do, and small liver resections, but not something like this. So this is a large HCC, not biopsied. It's a non-cirrhotic liver. Clearly, transplantation is not an option, ablation is not an option, resection is the only option. I was a little bit anxious because I don't have registration to practice in Sri Lanka, so I said, let's do this together. This was the case. If you look at it, that parenchyma in the left lobe looks okay. This is me over here. So I was holding the liver up. I took a colleague, so two of us went. This is Professor Dharmapala. That's us there. He did the transaction with Harmonic and the Aquajet. And the interesting thing about the Harmonic is they had the number, and when they took it out of the tray, number 48 on it. I asked, why is 48 on this? Because we use it up to 50 times before we get rid of it. So this was the resection, this is the patient. Did okay, went home. I asked this year when I went in September, a few weeks ago, how is the patient doing? He's doing okay. He has another HCC in the remnant liver, a small lesion. I said, if you like, you should do ablation for that, no more surgery. So this was a useful experience for me, and we went from here to develop this guideline. So how did we do the guideline? We developed a framework. We did a professional level literature search of what was already out there, EASL, NCCN, and BCLC as starting points. Had people from China, Netherlands, Singapore to help me with this. And we sought representation from every chapter of IHPBA. So there are 2 or 3 political things in this. This was one of the first political things. Do we invite all of the countries where there is conflict? So I decided, for example, with Russia, and this was my decision, that obviously there are issues around Russia currently, but in Russia there are patients with HCC and there are doctors who are looking after those patients. So it was my decision, let's invite everybody. So invited representation from every chapter on the planet. That grey area is where there's no IHPBA chapter, so they have representation from the College of Surgeons of Central and Southern Africa. So we got representation from everywhere in terms of HPB, but we also got multidisciplinary input in terms of hepatology, diagnostic radiology, interventional radiology, all of these other things. This produced a guideline document, which we circulated. We got the comments from those people back, integrated them. This won't project this, basically see whether people agreed or disagreed. And then finally, this is what the guidelines recommend. It's not in print yet because it's still going through a political process, which I will explain. So primary prevention is really important for a global guideline. The guideline says we endorse the position of the WHO that vaccination against hepatitis B is recommended for all newborns and high-risk groups. Surveillance, the IHPBA guideline recognizes that surveillance isn't universally available. Even, for example, in places like China, where there might be a higher incidence of HCC, surveillance is not universally available. If it's there, you should use it, and if surveillance is undertaken, an ultrasound-based program is recommended. There was a lot of criticism of surveillance, and these are all the criticisms that basically we said various methods to increase consistency include the use of ultrasound-based LIRADs. What about diagnosis of HCC? So clinical assessment, blood tests. Should we retain Child-Pugh? This was a political issue because it had been removed in one of the earlier versions of BCLC. We retained it. That was my decision because everybody knows Child-Pugh ABC. So it's there, and viral serology. Viral serology, in Sri Lanka, they don't test for hepatitis B because they have a neonatal vaccination program. So of the last 500 liver resections that they have done, 2 have been Hep B related. So it's not worth the money to do Hep B serology. Tumor markers, just alpha-fetoprotein. There was some discussion about PIVCA, the protein associated with vitamin K absence. We decided not to have that because that's not routinely available across the planet. Radiological diagnosis, ultrasound is the first test, and then CT and/or MR. Obviously, hepatocyte-specific agents are preferred, but they're not usually available. Use LIRADs in patients with cirrhosis. Lesion biopsy, not routinely recommended. It has become standard care in the UK because of the IMbrave 150 evidence about atezolizumab, bevacizumab. But before that, we were not routinely biopsying, and we didn't recommend that it should be routinely done here. Transient elastography fibroscan was recommended because it can be done by someone who isn't medically qualified. ICG clearance is quite widely available now. Hepatic vein wedge pressure is invasive, and we didn't recommend that. So what about treatment? We kept the BCLC categories, and we heard some interesting talks now about liver transplantation. The problem with liver transplantation, it's a great treatment for early stage HCC, is that it's only available to a very, very tiny amount of the human population. So a very small amount of mankind has access to liver transplantation. So we can't say no in a guideline, but we can't say yes, do it, because then it's the same as everyone else's guideline. So this was written by Caroline Buis and Glenn Bonney. and they said it's not usually available. Integration into clinical guidelines must consider reasonable feasibility. We know that people travel. If you live in a country like Sri Lanka, where adult liver transplantation is not available, and you need a liver transplant, people go to India or Singapore. So identifying patients who are those who might benefit from it is still important. Liver resection is really the standard of care for early stage HCC, and resection was the first-line treatment modality. Extrahepatic portal hypertension obviously increases the risk of surgery. And then we did this step, which is really unique. So we defined who should do liver surgery. We had some controversial discussions about this. So we said, okay, this should be a table, that to do liver surgery, you need a surgeon with training and experience in GI surgery, and a surgeon and a team with training and experience in liver surgery. That asterisk means you can't define it in any other way. So some people go to a short visit, they come back and they say, I'm a trained liver surgeon. Maybe one day the world can agree what you need to do, but it's not there in 2025. But in addition to the surgeon, the anaesthetist, the theatre team need experience in liver anesthesia and surgery. Post-operatively, the care facility should be able to provide level 2 post-op care, diagnostic and interventional radiology and renal support. These were also slightly controversial, but they really should be there. So the document will say, if you have all of these things, yeah, do liver surgery. If you don't, then don't do liver surgery. So that's the step on that one. Treatment of intermediate is fairly easy: ablation, TACE, sorafenib or lenvatinib. If it's available, and there's evidence that it's generally now a little bit more available, atezolizumab and nivolumab. Himalaya did this complex protocol, and in the paper in Lancet, the Himalaya trial investigators said this treatment should be available globally. So will the company make it available globally? I don't think they will, but we left it there for now. That's why it's in blue. It may not be in the final paper. An advanced stage HCC. So when I went to Nepal, it's seen as a mark of, not shame, but it's almost like if you have advanced cancer, the patient doesn't go to hospital, stays at home, is managed without hospital care. So I understand that. You can't change cultural perceptions of cancer, but there are things that can be done. So we recommended opiate analgesia, drain symptomatic ascites, use spironolactone. So in summary, although the guidelines for resource-restricted healthcare, this concept isn't new. EASL don't do it. NCCN do a guideline for this, and they have a meeting for that, which I went to this year. The problem with NCCN's resource-limited HCC guideline is it's the normal one. They just take out liver transplantation and atezobev. So that doesn't really work. What is different about this is a guideline produced by clinicians who work in resource-restricted healthcare. So as such, it's the first, or it will be, the first truly global guideline. It's not simply NCCN, EASL, or ESMO. And it does highlight areas for aspiration. Martin Smith, who was the past president of IHPBA, wanted to keep this in, which is that if you work in a resource-limited healthcare system, Sri Lanka is a good example. They are developing liver transplantation through links with India and Singapore, so it keeps that aspiration that they can still do this in the future. So that's the process. Thank you very much for your attention.